Andrew, Des, Osama, welcome to the podcast. Super excited to have you all here today. For people who aren't familiar with you and your practice and all the incredible stuff you're doing in this performance and rehab world, would you mind filling them in a little bit about who you are and all the amazing things you've got going on?
I'll go first. I run a cash pay practice, like training and treatment in Scottsdale, Arizona. Um, uh, I primarily just work with professional athletes in every sport, but my background before the private side was I was on the team side for a number of years. So I was a strength coach, an athletic trainer, a performance and medical director, and a rehab director. So worn a lot of different hats in the pro sport space on the team side prior to getting into the private side, and then start traveling and open up kind of the brick and mortar side of things, and like still travel some and consult as well with teams and individual athletes and their agents.
Okay, my name is Desiree. I'm a chiropractor. I work down here in Los Angeles, California, and I see people anywhere from the ages of 8 to 80, actually like 91 years old right now currently. We have, Grandma Betty, and we have young guns, and we have everyone in between, people that are coming back from pain, injury, trying to get back to doing the things they want to do. And our philosophy is that rehab is training. And, what people come in for pain, they usually stay because of the way the training makes them feel. And we often confuse people because by title, we are chiropractors. But at the end of the day, our end goal is to get people to doing the things that they can do for themselves. And how do we support that along their journey is very unique and personalized to everybody that walks through our door.
My name is Osama Imam. I'm a physical therapist up in Detroit, Michigan. I'm also fellowship trained in orthopedic manual physical therapy, and I teach dry needling through the American Academy of Manipulative Therapy. So, travel teaching other professions really across the country how to dry needle. I have a cash practice in Detroit, and I see everyone from youngest I have is probably 14 years old right now. And I got a couple 80-year-olds, but really everybody that I see is active to some extent, whether it's just recreational athletes, attorneys that want to be able to lift weights to reduce their stress, anywhere from Olympic fencers and a couple of college and pro athletes as well.
That's incredible. And obviously, you all have a wealth of knowledge and experience and also different backgrounds from more of a S&C ATC background to a chiropractic background to a PT and fellowship background as well that way. And one of the common overlaps between all three of these professions is the inclusion of manual therapy into the day-to-day practice, right? At some point in your day-to-day flow as a chiropractor, AT or PT, the majority of us are going to be putting our hands on patients, whether it's to increase range of motion or address a specific tissue restriction or whatever it is. There is largely some kind of hands-on component, if you would, to what we do. And for some reason, I feel like there's so much misunderstanding and misconception around manual therapy, what it is, what it does, what maybe it doesn't do. And I feel like the three of you represent a phenomenal group to really clear up some of these different things. And I'd like to dive in first by just asking, what do we define manual therapy is? When we say, oh, we're going to do some hands-on treatment or we're going to put some hands on people that way, what does that come out as? What does that look like for you? Does that go into like right into mobilization and manipulation? Does it go into soft tissue? Where does your mind go when you hear someone say manual therapy?
Well, speaking for myself, when somebody says they're a good, like a manual therapist, my mind immediately goes to like soft tissue and like your ability to invoke at least perceptive change to the client or the athlete or whomever you're working with. Cause I think at the end of the day, that's what it's all about. That's why I've never understood the school of thought of like, oh, like no, manual therapy doesn't do anything to research. Like I could tell you just now being on the outside of things, like that's what athletes are looking for, like people that are good with their hands and that make them feel better. So whether you want to believe it's a true change or not, um, they feel the change. And I mean, you mentioned the placebo effect when we got off online or when we were offline. I mean, that in and of itself has better results than, what 90% of what's done in the practical world. So who cares? I mean, on some level, like it's about making your client feel better, and moving the needle. So like then you, in my opinion, like you can get so far, you can clean some things up where, hey, like it doesn't come back. Like we've all had those instances. But like more often than not, when you're dealing, especially if you're dealing with more chronic things, like you're gonna have to get it to a point where like, hey, we're good. And now the finisher to me is generally an exercise um prescription at that point. But yeah, I think at the end of the day, like to me, it's whether you do like go straight for the tissue, whether you go more for the joint, like at the end of the day, it's all tissue. So, and you're having a input on the brain. So I think there's always one thing one of my mentors always said to me is like, no matter where you're at, like you may not have like any modalities, but you're always going to have your hands. And like, especially when you travel or if you are on the team side of any sort, um, if you make a house call, like let's say if you're modality heavy, but like it breaks, you should still be able to rely on your hands. And I think as a whole, the industry would do a great job if they put a lot of their focus just into that space.
So, being a chiropractor, you're literally known for using your hands, which is really interesting because going through the chiropractic curriculum and all of your training, they do talk about like your hands are your number one tool. I remember going through school and being afraid to go do things because I was like, if I hurt my hands, I don't know what's going to happen here. And people do, to your point, Andrew, they come to you expecting, especially when your title is chiropractic, that you are going to be putting your hands on them. We are going to be doing this thing to you, and we are going to be making some sort of change because of that. And again, like whether we believe it's placebo or not, whether that we know the evidence supports that that's actually going to make a difference, we know that these are still inherent biases and beliefs that people are coming to us with. And so understanding that yes, you can make some changes and maybe you're altering the input that's going into the brain. And so again, to your point, like we're always going to follow it up with some sort of exercise or get somebody moving on their own. So that way there's not this full, what's the word I'm looking for? Reliance on these manual therapy modalities. Cause again, they're nice to have at any place and any time. But if we're working with somebody, they can't do the same things that we are doing to them, if that makes sense.
Yeah, well, 100%. I agree with everything you guys both have said. And I think one thing that's important to your point, Desiree, is that really, if somebody's coming in expecting something, we kind of have to give some of that to them. I had a mentor who would tell me that sometimes you have to give people what they want so you can shove a whole lot of what they need down their throat. And really, that's evidence-based practice, right? Evidence-based practice is three pillars. It is what the research says, which there's research that supports pretty much everything that you want to do, right? There's research that can say that manual therapy can help in the short, medium, and long term. There's research that says that it doesn't help. Same thing with exercise, really. But while evidence-based practice does include research, it also shows that you have to do what the patient wants, right? It's patient's expectations as well as clinical experience. And if I know that I've had somebody that comes in with low back pain, and in the past I've done a manipulation and that has improved their symptoms and they can have more range of motion or they have less hesitation to move, then that's still evidence-based practice for me to utilize that. Really, evidence-based practice and manual therapy more so is an umbrella term. Manual therapy could be me putting my hand, just resting it on a patient, or it could be me doing some soft tissue work, some body tempering, some dry needling. It could be me doing a mobilization or a manipulation. So like you were saying, Des, yes, our hands are really one of our most important tools, uh, as well as our brains. It's not just what we are doing, but why we're doing it for that patient, right? We're mobilizing because somebody has an increased end feel and has limited range of motion, not just because it feels good for the patient. But that's still important, right? It should feel good for the patient, right? We have to get these short-term improvements in order to even keep a patient long enough on our schedule to get a long-term improvement, right? We have to build our trust with that patient in order for them to come back to us. And like we were talking about when we were all flying, right? Improving their sleep, their eating, their training. But in order for us to build that trust, we have to give them what they want initially. And to be honest, people want manual therapy. And from my perspective, I'm in a cash practice. I teach a lot of exercise. I load in the clinic, but more than anything, I do manual therapy because I need to do what they cannot do on their own, so I can teach them what they need to do on their own outside of the clinic. And all of my clients are already training. We just sometimes have to modify how they're training, how we have to appropriately load them. Like, there has to be the right amount of load. And I want to teach them how to do that on their own time, so that way I can utilize my hands and my brain in order to teach them what they need to do on their own. And that's honestly how I've gotten better outcomes as I've been in practice longer and longer.
And as you all alluded to too, there's this kind of short-term benefit that we definitely look for with any type of manual therapy, whether that's going after soft tissue structures or joint specific things or the spine or wherever we're looking at that way. We expect people to feel better afterwards. And especially for those working in cash-based settings, that can be the difference between, from a sales standpoint, they want to feel better and they want to feel better now. Hence the reason they're not going through that traditional insurance route, right? I'm sure we've all worked in insurance-based settings in the past, and we know people get very minimal, if any, manual therapy there. And one of the things I found, even when I was working in an insurance-based setting, is most of the time I spent around manual therapy was actually education and clearing up different beliefs or misconceptions and what it does and maybe doesn't do, as opposed to actually doing it. A lot of times people come in with this preconceived notion of, oh, you're just going to release a knot and then I'm going to be good for the next year. Or I'm out of alignment. You're going to do some spine manipulation. And next thing you know, I'm set, I'm good, and I don't need to come back. And a lot of times it's more so educating them, not just of the terminology, but how those things maybe came about in the first place, and how it's not just a one quick fix and then you're magically good for the next year, unfortunately. Interested to hear from you all about some of the terminology components, because I've heard this thrown around a lot of different ways by patients, by other clinicians. Some might call something a knot, others might call it an adhesion. Some might say, well, I can palpate it, I can feel it, and it just feels so tight and guarded. And I do think there is a huge art and science to actually palpating tissue and being able to pick up what you feel. And I think that's becoming a lost art in today's day and age. And I think, provocation testing is good, but I think there's a lost art of palpation. But I think a lot of the times our terminology or our wording around this almost confuses people more than it's worth that way. And I'd love to hear your thoughts on how you label different things when it comes to the terminology around manual therapy, and how you even just interact with your clientele about what manual therapy is actually doing versus maybe not doing for them.
That's a multi-layered question. I don't know. I've learned a lot of different manual therapy techniques over the year. And I do think, like, on some level, like, you have to be making some sort of chemical change. Now, and you can see that, like, if you back it up with diagnostic ultrasound. Um, it depends on the technique. Like, I explain it differently if I'm dry needling as opposed to, like, using my hands. I use a lot of fascial manipulation, stecco. And I mean, I started doing that about a decade or so ago, as it just gave me, on the team side, like, I could make change quick, and I could make uh like large scale change, and, like, not necessarily treating directly to the area. I think it was, I don't know if it's Shaitao or Leon Shaitao, or if it was Thomas Myers. No, it's Carol Levitt. So I was totally wrong. So Des, you should appreciate this, because I'm sure you guys talk about Carol Levitt in your facility. But he who treats the side of pain is lost. Typically, I 100% agree with that statement. Now, the flip side of that is, like, you also have to treat the side of pain a lot of times to get buy-in from your patient. Now, once you've gained some trust, that's a whole other thing. But I I typically talk about, like fascial layers, or, like, I try to meet the patient where they're at. If they call it a knot, cool, we're gonna call it a knot. They're like, so I just go off whatever they want to call it. I just use that in conversation to explain how we're creating a change. And, like, usually when you treat something like, hey, my uh, athletes laugh because they're like, oh, are you going to treat my big toe and my shoulder's going to feel better? So it's to me, it ends up being an education on explaining relationships and how the body works from sometimes from a developmental perspective, but sometimes from a neurological perspective, but in their terms. So I don't like to overcomplicate things. And I never want someone to feel like they have to be dependent on me. And that goes back to the exercise portion, Osama commented on, like, because ultimately that is what will give you lasting change, like long-term lasting change. So it's a paradigm. It's not a one-stop shop of like, hey, we're going to treat this one stecco point, or we're going to treat like this with ART. Um, and I do think our subconscious drives a lot of these things in the first place as well. That's where a technique like fascial distortion model does a really good job, because I think our subconscious drives so much of what we're experiencing. And for those of you that don't know about fascial distortion, they talk about having these distortions through the body, but like how I show you on like my body, on like what's going on, that's telling you what's going on with the tissue. Because I think the same thing after an injury, like somebody goes down to bend, like stretch their hamstring after a hamstring strain. I don't think it's them trying to stretch the tissue. I think that's a subconscious way of trying to get as much blood to the area and help revascularize the area like as soon as possible. But again, I think these are all like subconscious things that we then need to think about. That's a tangent. I'm sorry.
Gosh, I mean, there were so many really good points with that, Andrew. And I think the first thing is this is a loaded question, and there's so many layers to this. And like each one of those individual questions and points that Dan brought up could obviously be their own separate topic for another day. In a nutshell, I think our ultimate goal is always just to understand like the person's like biases, like you said the words they come in with. Like if they call it a knot, we're gonna call it a knot. People come to me all the time and they're like, my SI joint is out of alignment and I have a leg length discrepancy. And, a lot of times in our practice, because we are cash based and we are not the cheapest one on the block, we understand that the people who come to us have seen a lot of other practitioners and probably in a lot of different models. So the number one thing I'm up against a lot of the time is the beliefs. Like, what does this person believe is actually going on with their body? Where did this come from? And I know not everyone has the luxury to be able to unpack those things with the people they work with. But when we understand that this is something that this person genuinely believes, we can't just go and kick that sandcastle down. So if they believe a chiropractic adjustment or that massage is going to help them, or that dry needling is going to help them, insert modality there, then there's an element of that we have to understand. Like, hey, what about this helped you in the past? Or why do you think this is? You can give them a little bit of what they want, but ultimately the goal is to get them loading and moving at the end of the day. But it takes a lot of time and understanding that we have to build this trust with this person that we're seeing and recognize what they believe. So that way we can actually start to move that needle and get, pun intended, get them to where they want to be.
And to that point, and Dan, your original question is to like, how do we explain this to patients? Really, I ask them what their expectations are day one, and that way I can either, you know, redirect their expectations or meet or exceed their expectations, right? If they come in and they're asking for whatever it may be, then that is what I'm going to give them. And like you were saying, Des, a lot of the patients that come in and see us when we're cash based have typically seen other providers first, and they may have some expectations, but if they've already tried a ton of manual therapy in the past, one, I have to ask them what that manual therapy entailed, right? If their manual therapy was just massage, then maybe they do need a joint mobilization or a manipulation or needling done, or maybe they've had needling done in the past and I have to explain how I do things maybe a little bit differently. Maybe I needle them under ultrasound guidance so they can see that what I'm doing is a little bit different. But if they've done manual therapy in the past and it hasn't worked, maybe we just need to load them a ton more. Or conversely, when you're asking about insurance-based practices, in an insurance-based practice, it's very easy for me to manage 4 people at once that are doing exercise, and I can bill significantly more money for an insurance-based practice because that's what my boss was asking for. But if you're doing manual therapy, you can only really do manual therapy to one person at a time. So if they've gone to these mill practices and they've had a ton of exercise, maybe I do need to do way more manual therapy then, because they haven't even tasted that in the past. And then that'll allow me to transition them into more one-on-one training because like one of you were saying earlier, either Andrew or Des was mentioning that like this is a blend really of like rehab and training. But when somebody has done good training in the past, then really I can just focus on the manual therapy, right? A lot of people have really good strength and conditioning coaches or really good personal trainers, and I'm not going to act like I am better than them. I'm not really. Like, strength and conditioning is it's a whole specialty. And I am not that good at loading for me to be focusing on. I know what my specialty is. Like, I'm really damn good at manual therapy. So that is what I'm going to do more so with my patient. And if they don't have a good trainer, then sure, maybe I'm going to do some training with them. But if they already have somebody who is a good personal trainer that they're working with and knows what they're doing, then I'm gonna know my limitations and I'm gonna send them there when they need more of that, and I'm going to focus more on what I know that I'm good at. But all of that, I think, comes down to us asking them what their expectations are from day one, so that way we can meet and exceed their expectations. And really, I'm going to underpromise and over deliver every time.
I think that's huge, that concept of under promising yet over delivering, because again, going back to what we said before about that short-term buy-in component, when people feel better afterwards after doing this, they are locked in, good to go for pretty much whatever you want to tell them. And I think that's so essential, especially working with athletes. Like when I get someone on the table now, if they get off and they're not better, there's almost this kind of disappointment for both of us. They have this expectation that they're going to feel better after we wrap up whatever we do. And one of the things that you've all hit on to a certain extent is that manual therapy itself is very broad. It covers a wide array of techniques and different concepts and so on that way. I think part of what makes you a good manual therapist is knowing when to reach for which tool in the toolbox, right? Like Andrew was going on about Stecco's fascia manipulation. He mentioned ART. Osama, obviously, you taught me dry needling. Like I would not be needling right now if it was not for taking courses with you and learning about how to needle the lower extremity and the low lumbopelvic hip complex and so on that way. And I think that part of the art of getting that successful get off the table and wow, that feels so much better. Look at how much better I move. Part of it comes from actually knowing different schools of thought around manual therapy and knowing when to reach for which one, right? When do I do a MWM versus when do I just do, sustained PA glides or something like that, right? When do I go with maybe a myofascial cupping technique instead of putting a needle in there? Or when do I grab a scraping tool versus just use my hands, right? Like all of these little things can make a significant difference at the end of the day. And I think that, as you all alluded to, actually knowing these concepts and knowing how to apply them becomes the secret sauce at the end of the day. Has there been any techniques kind of under that technique umbrella or library, if you will, that have stuck with you to that point where it's like, hey, look, like this is where I'm going to reach first. I'm always going to reach for the needle first for this specific thing because of X, Y, and Z. Maybe it's neurophysiological changes that come from it, or maybe it's more of the pain chemical construct that exists with that technique. When people come to you and they want that instant relief or instant improvement in how they feel that way, what's your typical go-to? And you can take that any way you want. I know it's loaded. They're all loaded. But if you want to apply that to the knee or the ankle or the back, take it wherever you want to go. Would just love to hear kind of what that initial go-to thing is going to be for you, because everyone's looking for that immediate relief.
Been different things at different points in my career. But I would say pretty consistently at this point, like Stecco is my first thing of like, hey, I'm going to make this global change quick. Like go through my assessment. I'm going to identify where I need to start. And then it's like cleaning up with other things. Like that's when I'm going to bounce out to like, okay, I've got to do something more specific to the joint here. I need to do something. Maybe this is ART. Maybe this is FDM. Maybe it's, I think all these things blend together so much. Like even how I use Stecco as an example, like I use more of like a star pattern, which is how Janet Travell, that's how she would inject trigger points in the first place. So it's like all these things ultimately are a blend. But for like quick global change, at this, like today, Stecco gives me the biggest bang for my buck to be like, okay, we're going on the right track or we're not. And and like that's even how I needle. So like I'll needle Stecco points, but that's usually not my first go-to unless I've got to see multiple people at once, typically, or I just have a lot of area to cover.
No, and I think that's a very important point is that like I think it's evolved for many of us in our practice. I think like, even Craig, who I work alongside with at one point in time was very manual therapy and very, very hand heavy. In chiropractic training, like in school, it was always like, all right, you're going to adjust, you're going to soft tissue adjust, and then you would do your exercises. If that was your plan of attack. And it was like almost what you did for every single patient. Now, my go-to sometimes would be more ART, more soft tissue. Maybe it was more trigger point release. Maybe it was more like Mackenzie hands-on, like overpressure, or maybe even like neurodynamics. So there was a lot of different things like in our tool belt that we would implement. I think now as a practitioner, the thing I lean into more than ever is just like a good manual therapist or a good chiropractor knows when to adjust, but a great one knows when not to, right? So it's like, how do we give the most? It's just like training. It's like, what's the minimal effective dose? Like, what can I give to somebody that's going to get the most bang for my buck so I can get what we need to elicit, what kind of adaptations we want to get out of the person. And whether that's because I'm putting my hands on them or I'm loading them, the principles are still the same. What's the minimal effective thing? What's the least thing that I can do that's going to actually do something for this person in front of me?
I think you make a great point, Des. Like it's more about knowing when not to do something. And I think when I was initially, when I first graduated, I went straight into fellowship. Like I did a ton of manipulation, way more than I think I needed to. I had one mentor who told me that you have to mess a lot of people up to actually get good. And I think I did a lot of that because it was almost like this is a shiny new toy. I wanted to use it on everybody. And then I realized that I was doing it a bit too excessively. And I think that a lot of what we do is a science, but almost more so, it is an art. It's a lot of experience of knowing when to utilize something. And I think that probably one of the things I go to first. People know me as the needler, probably because I teach it and my Instagram handles Dr. Cracking Needles because it's funny. But really what I do more often than anything is mobilization, at least for more of my male patients. I think that a lot more of my male patients are going to be more hypomobile. A lot more of my female patients, just, painting with a broad brush, a lot more of my female patients are going to be more hypermobile. So typically it's going to be a bit more loading of, proximal joints for a lot of these patients that are more hypermobile versus a lot of the patients that are more hypomobile. I'm going to mobilize, but I think that if it were just exercise, then they probably wouldn't hurt because most of my patients love exercise. And it's more so of getting something to maybe move a little bit better. Like let's say something is hypomobile and we get maybe a short-term change in their range of motion. Well, in order for us to actually keep that, we have to at least get them moving to some extent. So, I'm going to get something to move a little bit more and then utilize that new range of motion immediately afterward. But I think a lot of that also comes down to some activity modifications, right? Like if it were just exercise, they probably wouldn't be in pain in the first place because most of us are getting hurt from maybe doing some form of exercise. Like my neck is an on and off problem. There's probably something I'm doing that keeps pissing this thing off, but it's definitely not exercise because that's what I want to get back to doing. That's what I enjoy doing most of the time anyways. So I think that it is maybe activity modifications coupled with knowing when to utilize something. And it doesn't just come down to maybe a specific type of therapy, whether that is exercise or manual therapy, like Stecco or ART. Like I don't do any of that. I do a ton of needling. I do a ton of mobilization, a ton of education, some soft tissue, whether that is just utilizing my hands or maybe a dynamic or static cup. And then we're going to get them moving to some extent. But I don't think it has to be as specific as like, you got to do a mobilization with movement. You have to do Mackenzie. There are some points where I am going to do a mobilization with movement. I am going to do Mackenzie with some overpressure, maybe some Colton-born techniques, or maybe I'm going to needle some acupoints or needle them under ultrasound. I don't think it always matters to the extent of like what you're doing specifically. I just think we have to do something for our patient. Again, you got to give them what they want so you can give them what they need. And while I don't do a lot of these manual therapies that maybe you guys do, I don't do any of the ART or Stecco, but I think us just utilizing our hands to some extent and showing them that they can move with less symptoms puts a thought in their mind that like, I'm not broken, right? It's not just like I need to go down a surgical route. All of this is a conservative treatment. Like the most invasive thing I do is putting a needle inside of somebody. So everything I do is, pretty conservative. And us utilizing that in combination with movement shows them that they can move with less pain, which over time shows them that if I just stick with this long enough, if I just do my homework and listen and start to improve the other aspects of my life, then I can get back to doing, whatever their goal is.
I think Osama just hit on two major points. The technique doesn't always matter because in my experience, the longer I do this, man, like everything works. So all roads lead to Rome. They really do. I think that's like the body in general. And that's why as long as you have a clear intent, and this is exercise, this is therapy. To me, it really doesn't matter. Like have a clear intent, like you have your end goal. I want to get to Rome. Cool. Like that's up to the practitioner. That's where the art and science meet one another. And then you made another comment that to me, like I think about this a lot, is I didn't appreciate it as much on the team side, and then I started being like, oh wow, like when I first got on the private side, I was seeing both athletes and Gen Pop. Everybody's just looking for hope at the end of the day, and I think that no matter what input you use, like when you provide them hope, number one, like that's your hook from how you like get a client and start get referrals. But like that's when people get motivated to like really try to find a way to get better at that point. Like if you provide them hope that they can feel better, then it's like, all right, what's next?
And I gotta just like piggyback on that because that's just way too good. Like I think at the end of the day, like our philosophy at LA Sports and Spine is like, how do we get on day one, people need to leave with tangible hope and an achievable plan. And I think as much as that can happen via a hands-on modality, I think it's just understanding that like we are helping this person in front of us understand that they're not fragile and they're not broken. And here's how we're gonna go about it. Maybe it is we're starting to expose their body to things that they haven't dealt with before. And we're the first practitioners that aren't promising that this is just going to miraculously disappear overnight, but like we're going to sit in the mud with you a little bit and we're going to help you figure this out together. I think if I could go back to Dan's original question that led us down these tangents, I think he said, what's, the most important modality or method that we use. And I think for us, at least in my practice, it's conversation and kind of understanding the person in front of us and what makes them tick and why they feel that way and what beliefs they have. And then how do we subtly challenge those little by little over time, whether it is hands-on care or hands-off care. Like I call myself the hands-free chiropractor because now it's like I barely put my hands on somebody unless I absolutely have to. And so I think that's really important for people to recognize that there's no wrong way of doing it. The research supports that you could do anything and there will be change with time. But I think it all boils down to physiology and psychology and how do we have these conversations with people so that they do feel like there's hope and they can do more than they thought when they came into our office.
And I think that concept of someone getting that hope really is what causes what we were talking about before, that short-term immediate gratification that often comes after manual therapy. And one of the other things, Osama, you dropped the S word, surgery or surgical in there. And one of the many places that I've found a ton of value from getting hands on someone is post-operatively doing some effleurage and actually getting the effusion to move along and clear out a little bit, which I'm not making any groundbreaking or earth-shattering changes like that by any means. But there is something about that concept of just moving fluid that has led to a lot of home run shots, I guess I'll call them that way. I just think about those patients, maybe post-op ACL, laying on a table, puffy knee, and you effleurage it for a bit, and next thing you know, they're actually able to fire their quad and get a legit good quad set and firing what they need to and not what they don't need to. And it's like those moments like that, to use that term hope again, those are the moments that people are fully like, oh wow, I'm invested in this. It's going to work. I can see improvement and so on that way. And I think effleurage was just the thing that came to mind as you mentioned that word. And Des, you also mentioned something phenomenal about knowing when to manip versus maybe when not to manip. And that's something that I know I've texted Andrew about a number of these cases where sometimes being the second or third or fourth clinician to see them is actually a benefit, because you can ask them, hey, what did you try before? What didn't work? And when I get those insights, then I can have that conversation about like, well, maybe you've had this hamstring issue, but they never addressed your adductors. Maybe we need to go up the adductor chain because the close relation there, or going to more regional interdependence for a second. How often do you get someone with neck pain or headaches, but no one's ever touched their T-spine? They've just adjusted the neck over and over again. And then we crack their T-spine and all of a sudden the neck is better. It's like, it's crazy. But sometimes going where we don't believe there to be a injury, if we want to use that term, actually leads the injured tissue to improve. And I think that's one of the fascinating things about tissue in the body as a whole, is we can intervene somewhere regionally close to, but not directly of the site of injury or dysfunction or whatever we want to call it, and make significant improvement there. And I think knowing that concept of maybe going other places from the start might help us get to that hopeful moment better and quicker.
I think you hit on a lot of really important points, Dan. I just grabbed this book called Surgery, the Ultimate Placebo, which I have sitting in my waiting room for patients to be able to like maybe second guess, their preconceived notions. I even had a patient in the past, you kind of alluded to this, Dan, about maybe treating not the direct site of pain. I think a lot of patients, by the way, are spine related issues that are going unaddressed, which is one reason why I think even with the conventional chiropractic model that it can work very well. I mean, there's research that shows that even consistent care from a chiropractor by a chiropractor is better than episodic care. So maybe we should be treating patients and maybe not discharging them, because you don't get discharged from your dentist or your primary care physician anyways. But I had this one patient in the past that had a hip replacement, and she came in to see me. She goes, my hip pain has not changed. She had it maybe like 6 months prior. Her hip pain never changed. And the whole time it was a lumbar radiculopathy that was never checked for. And you can have a lot of damage on an image, right? Like she probably has a very arthritic hip, and that's why they did the hip replacement in the first place. But you can have a lot of damage technically on an image and not have any pain. I mean, look at Achilles ruptures. Like it hurts initially and then it completely goes away. And sure, it builds up a swelling and starts to hurt more and more because of that. But technically, like with the actual tear, there's nothing left to hurt. So a ton of damage on an image, but no actual pain associated with that damage. So similarly, with an arthritic hip or whatever else it may be, there could be a ton of damage and no pain. I mean, I've had patients with shoulder issues that they need a rotator cuff repair, but no one addressed that they have a cervical radiculopathy that was completely missed. And the entire rotator cuff is innervated from the cervical spine anyways. So I think a lot of the time, like the main issue is that they're not even being evaluated properly to know what to do for them, whether that is manual therapy or maybe it is surgery, maybe it is medication, right? Like I'm not completely opposed to surgery. There is a time and place for everything, but I think that maybe it's because of the insurance model that has completely changed and people don't go down that conservative route anymore, right? They think that they're broken and they need surgery, but then they don't ever recognize that there is a bias towards what somebody does, right? I am biased, obviously, towards physical therapy. It's what I do every single day. It's how I see people get better. And surgeons are probably going to be biased towards surgery, not to any of their fault, right? They've seen people get better with surgery. Otherwise, they wouldn't recommend it in the first place. But it's like going to a barber and expecting something different than a haircut, right? You're going to probably like, the quote actually is mentioned in this book as well, where they say that any surgeon can operate. A good surgeon knows when to operate, and a great surgeon knows when not to operate. But a lot of the time they end up just doing surgery because they think that they're going to need it eventually. So they might as well do it now. Or, they just got to pay for their vacation because that's how they make money. Let's be honest.
I think you hit on a number of good points. At the end of the day, we all have our biases. And I think like we're a hammer and then everything's a nail to an extent. And like surgeons are no different. That's why like I always know surgeons like, oh, okay, if you go see this guy, like you're going to be leaving with an operation. But I also think like people are looking for answers at the end of the day. So like they latch on to diagnoses, and like that can be a very slippery slope and dangerous game to play. Because once somebody's like, oh, like I've got FAI in my hip, like that never leaves their mind. Even if like, in your heart of hearts, like yeah, like you have that structural change, but that's probably not your issue. To your point about like the radiculopathy that just went unchecked, like that stuff happens all the time. And then like you have a good treatment session with them. They're like, hey, like you didn't even touch this, but like my FAI all of a sudden's better. Like, how did that happen? Like, well, like, because it's not your FAI, but neither here nor there. But like that is a game we have to be careful of, because no matter, they'll hear one thing and they'll learn one thing from their doctor or their team or a previous therapist, that's just always in the back of their mind. And like we can add to the problem if we're not careful. And we have to be very mindful of the things that we say.
I just was I'm so glad you said that, Andrew, because I think that in our space, especially because we're usually later on in somebody's trajectory, like those labels that people are getting, they've like identified with them. That is their whole personality. They are, I am so and so. I'm Desiree, and I have airless downloads, right? Or like, I have, I am sciatica, not I have sciatica. You know what I mean? Like it becomes somebody's like whole personality, and it's exhausting as the practitioner to watch somebody go through that experience and be like, look, like these things can change. Like these things, you don't have to live with this forever. But because someone well-meaning probably was trying to give someone that answer of here's this thing that you're experiencing and here's what to expect with the thing, that this person just embodies it because they're frazzled and they're afraid. And so it's really easy for a well-meaning explanation or answer. To your point, people want answers. We're trying to help them by giving them answers, and sometimes we're creating bigger monsters and bigger problems. And so how do we have those conversations with somebody and help them understand that it's okay to have these things? These are really normal. And like again, bringing back to the evidence, an evidence-based practitioner, like you can show them the evidence, like, hey, like 40% of 40-year-olds, oh, you have, disc degeneration, but like DDD is a scary thing. So it's like, how do we communicate these things and normalize them, but um, not be dismissive and recognize that these biases that people have and these diagnoses that they have are their real things, just like we have our things. Like I'm a chiropractor, so naturally you think I'd be biased towards putting my hands on somebody, but my true bias because of my background is exercise. So it's like, how do I communicate that to somebody without dismissing the fact that they believe a chiropractic adjustment might help them? And how do we get to a conversation where we can actually, get things moving forward for the person?
What's funny is I'm a physical therapist, and my bias is probably towards putting my hands on people. And again, I love exercise. I push people towards it. But I honestly think that, at least within my field, manual therapy isn't done enough. And that's maybe because of the insurance model and somebody seeing 4 patients at once. And again, like, you can't do manual therapy to 4 people at once. And also, it reimburses less money than exercise does. So, like where I used to work, everybody started off with an 8-minute warm up on a treadmill or an arm bike. That's because it was 8 minutes so I could bill them. But when they come in here, it's usually a conversation for 5 or 10 minutes first. And then I'm probably going to do a little bit of manual therapy. I'm going to go over their home exercises because they always do it wrong, even though they got videos and a write up and everything. And then we're going to, maybe change some exercises or add some more. But I honestly do go down towards manual therapy route first. And it could be something I'm doing wrong, but I also can tell you that a lot of people are just not addressing the problem with their hands at all. And I've had patients that have gone down only an exercise route and haven't gotten better. I mean, I can't tell you how many patients with knee arthritis I've had that have gone down traditional physical therapy route or even seen chiropractors, and all they got was exercise. And yes, that is our end goal, but you don't start off with your end goal necessarily. And there's research that shows that dry needling works incredibly well for an arthritic knee. And if we do it consistently, if they have booster treatments, the more often they get them done, like if they got them done once a month, they did better off than getting them done once every 2 months or never having a booster treatment. So yes, I'm going to put some needles in a patient based off of my experience, based off of their experience of not getting better with exercise, and then also based off of what the research says. Or I have a patient right now with a meralgia paresthetica. She's seen 7 providers before me. She's had pain for a year and a half. And really what I did for her is not that complicated. Like, we looked at her lateral femoral cutaneous nerve on ultrasound. I needled around it. And then we did some dynamic cupping, and I've worked on her back a little bit. She's had people say it's just your back, or it's just, your hip, or, the nerve itself. I'm like, it's probably both. Let's be honest. You've had it for a year and a half, and we've treated both. She's only yesterday I saw her. She told me that she is 70% better now, which is like way better than where she has been. Maybe she won't become pain free, but if she's 70% better, she now can sit in the bleachers and watch her kids play soccer, or her grandkids play soccer, which is way better than where she was in the past. And going back to what we've said earlier, it gives her hope. Maybe she doesn't need a hip replacement or a lumbar spine fusion, because that probably wasn't the problem in the first place. And manual therapy is the reason that she's getting better. And now she has confidence to move around more and do exercise, because she already goes to a gym where she has good trainers. And now that exercise is going to get her that long-term improvement. But we had to get her a short-term improvement first to even get her to a point where she can get a long-term improvement.
To your point about that concept of putting hands on very early, Osama, one of the things I kind of played around with a series of evals that I did about a year and a half ago was everyone started with hands-on things, but those hands-on things, a lot of these patients were high school female athletes who were insanely hypermobile. Like they could bend their hips in places that would just absolutely crush me to get to myself. But I think one of the other misconceptions that we have around manual therapy, and maybe it's on me for not bringing this up earlier, but we think that hands-on only means more motion or more mobility, but sometimes we can actually use it to bring about stability. And I reached to a ton of manual resisted exercises and actually used some kind of hands-on cueing with that. And I kind of look at that manual resisted exercise as the kind of bridge the gap between manual therapy and exercise, if you will. And I found there was a lot better buy-in because people felt like there was a tactile element to it. They could feel it where we needed to. Obviously, be careful with that. Like, if you're going to go crush manual resisted hip stuff, like, don't just start putting your hand on people's areas that maybe they don't want to be touched. Like, you still have to be ethical about this stuff. But I think manual resisted exercises can be a phenomenal overlooked tool. And it also gives me, in my opinion, way more info than a base manual muscle test will, because I can literally change their position each rep if I'm doing isometrics, or we can manual resist the entire range of emotion, whether that's something linear or maybe more multi-planar, or however you like to think about your movement that way. I think there's a ton of value and benefit to that approach that way. And the other concept that I want to touch on real briefly was I think all of you mentioned that concept of, hey, is it really this diagnosis? Is it FAI or is it sciatica? Is it a hamstring strain or is it sciatica? And I think a lot of people now are getting maybe away from the diagnosis game, which in some ways people now more than ever are pressuring to get an answer, to get a diagnosis. But on the other hand, sometimes there is no diagnosis per se, right? Like, I think we're overly dependent and overly emphasized on what the term for something is, and maybe not emphasizing enough what deficits we need to address to get them feeling better, moving better, and ensure that what they're presenting with does not come back. And I think a lot of those cases almost become a game of chicken or egg. And I found, at least for myself, I've falsely made a lot of assumptions off of that in the past, right? Maybe they started having back pain, and then later on they developed hip pain. And I would maybe make an assumption that, oh, the back must have preceded the hip because it started hurting first. When in reality, maybe the hip wasn't moving like it should. Maybe it wasn't as strong and stable, and the back really was the thing, and the hip was the thing that kicked it off. I might have said that backwards, but essentially what I'm trying to say is we make a lot of assumptions when it comes to manual therapy and treating regions when we don't necessarily know the full story for a fact. And I've found myself guilty of that in the past. And I found the more I just focus on what they're presenting with at the moment, what I know to be true, and what I can do to address where we are right now, the more successful I am, as opposed to chasing all of the assumptions of the past.
I think on that note, something interesting that we've seen, just we do a lot of in-depth blood work with our guys, and something we see like over and over and over again is like really poor gut health with people that have chronic conditions, chronic issues. And like as soon as like that starts to get better, their chronic pain goes away. So like we have these and like I had a deep, I don't know if you guys have ever had a deep clean like for your teeth ever, where they get like under the gums. I had that last week, and immediately, like, I had some like hip discomfort, and like that went away. Like, so we have these systemic inflammatory responses that are happening like throughout our bodies if we're not taking care of certain things. And like when those get taken care of, like, that's not saying like, oh yeah, like I did something to irritate my hip actually running. So like I know I had something that happened, but like it's always gonna like an inflammatory response is always gonna go to the path of least resistance. So that's not saying like you don't have an issue someplace, but to kind of the theme of this last like 15 minutes or so is like just because you have an issue doesn't mean that's the issue.
I'm with you there too, because we see a lot of people, and we're in Los Angeles, so there's the uptick of all of these like wellness longevity centers here, and so it's happening more frequently now, where people are coming to us with like a preemptive body scan, or like, a preemptive blood work panel, and they're really in depth, and I think in a lot of ways it's been really helpful. Not just in getting people to be more preventative and proactive in their mindset, but just understanding that, like, hey, like these markers we're finding, if you've got some inflammatory markers going on, like this could be perpetuating what you have going on. We know that like tendons, Osama, this is probably your realm with dry needling. You know that an unhealthy tendon can also have a great or a better outcome to success if they have a better metabolic health. If somebody is poor metabolically, then we know that their tissues are going to have a harder time healing. And like you just said, Andrew, if there's something going on, like let's say right now I've got a shoulder, well, guess what? I haven't been sleeping well. All the other things in my life have been a little crazy right now. And so it makes sense why my shoulder's uptick. I haven't done anything drastically different in my training. It's just I can tell that my body is feeling a little bit more inflamed. And so this is something that people don't always recognize, but it becomes a great conversation point and a great adjunct to what it is we do with somebody. So if you are putting your hands on somebody, you're going to be doing an intervention, you can use that as an opportunity to have these conversations that, we can start addressing other areas, not just from the tissue standpoint, but like internally, your biochemical system, your ecosystem. We can start to address these things and have better outcomes with whatever intervention tool you choose to deploy.
Dan, I think you have some really good points with your initial question about like, honestly, who cares what the diagnosis is in the end, as long as they get the result, whether that's from seeing me or a different provider, I don't really care. I just want them to be better in the end and get back to their lives. And you had mentioned earlier that like manual therapy might even help with stability, whether it is through something like a manually resisted exercise, or maybe even, I mean, there's research that shows that needling the lumbar multifidi can improve thickness of the multifidi. Same thing with the manipulation, where if you can do a high velocity, low amplitude thrust and get cavitations of their lumbar spine, that you can improve thickness and activation of the multifidi. So maybe it is going to be some manual therapy initially, and then we're going to go deadlift like immediately afterward. Maybe we're not going to max out, but sure, we're going to at least get some weight on the bar. And it could be something that is, something that is systemic, like, the IV therapy spots are popping up everywhere. I'm sure that they're all over California and Arizona. But with that, maybe it is something that's systemic. Maybe they're dehydrated. Maybe that they're lacking in with a tendon. Maybe they need some collagen supplementation. Maybe they need to take magnesium with their headaches. And maybe it is a combination of that with whatever else we're doing. Maybe we're not getting 100% improvement with what I'm doing on my own, but it's the education and the things that they're doing the other 23 hours out of the day, the other 6 days of the week, because I only really see them for 1 hour once a week, the way that I treat. Maybe it's a combination of that and their sleep improving and that they're eating better and they're back in the gym. So I don't think it necessarily needs to be one thing, nor does it really matter. In the end, if they're getting the outcome that they initially sought out, then coming in to see me was probably worth with their time and money.
Last thing I want to sneak in real quick, as you mentioned previously, Osama, in relation to dry needling. There's so many different techniques out there, and a lot of people have had great successes with it, and some have had terrible stories from dry needling. And they just feel like someone punched them after their first session, and they're down and out for a week or 2 weeks, and they never want it again. And at least for myself, I've probably about 80% of the time gone to throwing needles in, leaving them in for an extended period of time. I do a lot of stim with the needles. And this is one of the few places where I actually have found more success with more, not less. And I don't think twice about throwing 15 needles in someone's lumbar spine or throwing 20 needles around a knee and a quad and so on that way. And maybe I should shift that and maybe I should go less. I'm sure the people who buy the needles would like me to use a little bit less because they're not cheap and you can't reuse them. But this is a spot where I found more is better. And with very few exceptions, I would say maybe lung fields where I just don't feel comfortable leaving a needle unattended per se. For the most part, we're letting them sit for a while. We're not really pistoning. We're not really trying to chew up or spit out tissue per se. We're really just trying to make a positive neurophysiological change. And I guess I'm just interested for those that do needle, just because it's come up over and over again during this. Has there been similar successes or anything that's really stuck with you as super successful principles applied for dry needling?
I've got a short anecdote, and then I'll let Osama, he's probably the expert in this area, take over. But I've just seen the trend of people, like I use a lot of Moxie monitors, and the people that have like it'll show up as THB, but it's essentially, let's just call it like the ability of your capillaries to vasodilate or constrict, and like what they're doing. People that are at the lower end of that spectrum. So if we're thinking about the oxygen dissociation curve for a quick moment, like people that are lower have like lower body temperature. You see this in a lot of females. They typically are going to have a better, like they just overall feel better after they get needled, because they're getting that big vasodilation effect. Now, people that are at the other end are usually, that's the Bohr effect, more like they're more to the right in that oxygen dissociation curve. Those are typically the ones that don't have as good of a result with needling, and they get a little more sore from it. I could speak for myself personally, like I have higher like THB, how it would show up again in the Moxie. So s- greater ability of my capillary beds to vasodilate. I feel like I have such a small window of being like getting a good result with needling. Like I like if I whenever I've gone to a needling course, I feel so terrible after. Where I know some people that like go and it's like they've never felt better after going to a needling course. So it just tells you kind of where they live on that spectrum.
I think a big part of it really is how much the patient can tolerate. Like if you look at the research, it says that a higher dose is going to get a better outcome. But like Des was saying earlier, and the way that Andrew's reacting is proof of that like we're looking for that minimum effective dose. I want to be able to put more needles in patients typically, but I have, a patient right now that she feels good afterward, but she hates the insertion of them. So if I was like, we're going to keep doing more, she's probably going to hate me. She's not going to come back in. She's not going to get better in the long term because I didn't even keep her on my schedule long enough to get her an outcome. So really it is dependent on the patient. I'm probably the opposite of Andrew. I feel I don't love the insertion of it. I don't, as much as I do it, I kind of handle it like a wuss, but I feel really, really good after getting needling done. So it is dependent, I think, on how that patient tolerates needles and probably their preconceived notions. Like I know that my neck responds well to needling, so please put more in me. But that being said, if somebody doesn't get my traps, then I don't typically feel better. Dan and I have already had a podcast episode on needling and the mechanisms of it, but I think that it depends on how somebody is doing it. Like if somebody does piston to my trap, I definitely don't feel better. I just get really sore afterward, and I don't really have a great improvement in thereafter. So it is dependent on whether they're rotating the needles, if they're doing fanning or coning, depending on the area, whether or not they're using electricity. The nice thing about electricity is that while it increases the dose and that they're gonna get, a better outcome, it also will reduce their soreness. So in my opinion, it's like, why not use it? As long as they don't have a pacemaker or something, like why not? But all that being said, I think it will depend on how much that patient can tolerate, which is the case from everything. Like I remember in PT school, somebody asked, how often do I mobilize? Like, is it every single session? Most people are treating 2-3 times a week if they're in insurance-based practice. So somebody asked the question as to how often do I mobilize, or how long do I hold it for? How many rounds of it do I do? And really, there is no good answer. My professor's answer in PT school was depends on the patient's tolerance. And every answer in rehab is it depends. But really with this more than anything, because if you do too much, I mean, there's a systematic review that showed that one of the studies talked about how up to 51% of people that get needling done do not want to be needled again, which is a crazy stat, because that means 50% of people that are getting needled are probably like the provider is doing too much of it, or at least it's not getting the outcome that makes the patient desire it again. So all of it will depend on how much that patient can tolerate and whether or not you're doing it at the right location and the right dose, right? If you are doing it in the wrong area, or if you're only doing trigger point dry needling, meaning you only are treating muscle because only muscles can get trigger points, then you're probably missing a lot. And I know that this is intended on being a manual therapy episode, not a dry needling episode, and we're going down this route, but that is the case really with anything that we're doing, right? If somebody has shoulder pain and I mobilize their shoulder a ton, but it's a hypermobile shoulder, I'm probably making them worse. If they have shoulder pain and I keep mobilizing their shoulder, but it's a cervical radiculopathy, then I'm probably not going to make any change. So it really depends on what is your intentionality between what you are doing and bringing it back to the evaluation. Like, do you actually have a solid, maybe you don't need an actual diagnosis, but like a differential, like it's at least coming from the shoulder area, not the neck or the thoracic spine or something along the lines. So all of it comes down to where their symptoms may be originating from. And it probably doesn't matter exactly what we are doing, but at least that we're getting an input in towards that area and then getting it moving in some extent afterward.
You made a major, like that's a crazy stat. The 50% of people don't really want to get dry needled again. Because when you start looking at the team side of this is all pro sports in the US now, that is what people consider manual therapy at this point. It's like they can do Graston, they can cup, and they can dry needle. This should take us right back to how this whole call started about just get really good with your hands.
Yeah. No,
I can't forget BFR. Throw that in the fear conforsum right there.
it is a full circle moment, and that's part of why I felt like we needed to address dry needling. Is it's becoming part of the manual therapy skill set, if you will, when a lot of times people view it more as a separate modality from an education standpoint. So I think it's essential to bring it up like we did that way. And as we start to wrap up here, if y'all have any Instagram handles, anything like that, where can they find you online?
I've got mine's Hauser _AT -SC. That's my Instagram handle. I have no idea.
I know you're more of a MySpace generation anyways. It's okay. I'll link to it.
I will spare talking about say I never had MySpace, but I was like first generation of Facebook. I was actually asking my wife, I wonder if I could like reactivate that account. Just wonder what pictures are actually on there from college. Be dangerous. All right. Thanks, everybody.
Y'all can find me at Back Into the Saddle, my Instagram handle, or first and last name 27@gmail. All of those work for me.
I'm very Googleable. I'm probably the only Osama that's a physical therapist, so you could just find me through Google. But my Instagram handle is at dr.crackandneedles. And I don't really use my Twitter or my Facebook at all. So probably just Instagram. I also have an online manual therapy group. That's the Manual Method. It's a school group if you guys want to join that as well.
And that school group has grown significantly. I remember when you first started that, and I think I looked the other day and there's like, hundreds and hundreds of people in there. So huge kudos to you for doing that and putting out a phenomenal resource for people like that. Is there anything that we missed as we were chatting today, or anything that maybe we didn't cover that you really wanted to get into?
I got one thing to add. I just think that it's interesting how online it's everyone talking about exercise more and more. And again, I love exercise. I'm not trying to like downplay it in any way, but you can't online sell manual therapy, right? I can have an online class on exercise, so that's why everyone's posting that type of stuff on Instagram. And coincidentally, everyone that hates on manual therapy also sells you a course of exercise for how to get rid of whatever pain. But I just think it should be a combination of everything. Again, I don't know every type of manual therapy. I don't know every type of exercise, but it should be really a combination of everything to get somebody back towards their goal. And we really shouldn't be pinning any professions against each other. It doesn't matter how somebody gets an outcome. It just matters that they get that outcome. And if we keep pinning every profession against each other, the only person that ends up losing is the patient. So really, it should be a combination of everything that we are doing in an interdisciplinary approach, knowing what our limitations are, when to refer, whether that is medication and surgery. I refer to chiropractors, I refer to acupuncturists, I refer to personal trainers. All that matters is that this patient came in seeing me because they're trusting me, and it is on me to make sure I earn that trust every day and refer them when it's appropriate, so that way they can get an appropriate outcome. And while I might make less money in the short term, I'm sure I'll make more money in the long term because people just trust me in the end.
Man, I think that's so powerful. I think, I teach alongside with Craig and Ryan Chow and Katie Dabrowski and all these really amazing like chiropractors and physical therapists and even coaches. And I think at the end of the day, like we all have the same goal, and it's helping the person in front of us. And if we remind ourselves of that and always keep whatever we're doing tailored to the person that we look at and we're sitting across from, I think that you can't lose. So long as you're doing the intent to help that person and you've got their back no matter what, I think you're gonna do a lot more for that person than any one provider ever could.
This has been a phenomenal conversation. I really appreciate everyone's time and insights and making this possible that way. So thank you all again, and looking forward to catching up with you all again very soon.
Thanks for doing this, Dan. This has been fun.
Thanks for the opportunity. This is a lot of fun.